Okay. What's up, science lovers? I'm Kayla, one of your cafe coordinators, and we're back with the Teen Science Cafe live stream. Before we go further, we'd like to invite you to subscribe to make sure you never miss another awesome North Carolina Museum of Natural Sciences video. Remember to be respectful in the chat, as our moderators will be keeping an eye on the comment thread, and please leave your questions in the chat. Also, check out Teen Science Cafe Raleigh on Twitter, Facebook, and Instagram. Tonight we've got an exciting guest for you. Our guest works for the North Carolina Department of Health and Human Services, and her focus currently lies largely in helping make data-driven decisions in the face of the global COVID pandemic. Tonight, she will be introducing us to the world of bioinformatics and telling us how she crunches the numbers to help protect and promote public health. Please welcome Dr. Tenenbaum.
Thank you so much. I'm so excited to be here, and thanks to the Teen Cafe for having me here. This is so much more exciting than sitting at my desk at home over Zoom. So, as was said, I'm Jessie Tenenbaum. I am both at Duke University and North Carolina Department of Health and Human Services, where I'm the Chief Data Officer. And I'm going to talk to you today about how we handle the data, how we use it for COVID, and some of the stuff we've done, and show you a little bit of a peek behind the scenes. I'm also going to talk a little bit at first about my very indirect path to a profession in informatics. So I know the word informatics may be unfamiliar. We'll talk about exactly what that means. So a little bit about my career path first. I thought I wanted to be a dolphin trainer, or short of that, a marine biologist. I thought that dolphins were really cool and I would love to do that. What I realized was maybe I just wanted to be a scuba diver. So I learned to scuba dive and got my training and got my certification, and then realized that I wanted to do that as a hobby. I did get a chance to volunteer at the Seattle Aquarium as a scuba diver there and feed the fish and clean the coral from the fish poop, which was actually surprisingly fun, and play rock, scissors, paper through the glass with the kids outside. I then went to college, decided marine biology was not what I was going to do. I was studying biology and I was really excited about both genomics, or at the time it was really genetics. Genomics wasn't even a thing yet. Genetics and neuroscience. Couldn't really decide what I wanted to do between those. A lot of people with me were taking jobs in labs and doing science and doing research and having good things to put on their resumes. I worked in a lab where they needed people to build test tubes because they went through test tubes so fast. It was actually faster to pay an undergrad to remake the test tubes than it was to buy all the test tubes. So I got to do a little fiddling with that. Not really science per se. Going through school, I studied biology, but then got to the point where I just didn't want to learn that much more about the nitty-gritty details of what's called G protein coupled receptors or other aspects of biology. And I looked at the course catalog and saw that there was a computer science course and thought that actually looks really fun and interesting. So I wanted to take that. This was in the middle of college, and the intro course that I would have had to take was the wrong semester. So it wasn't being offered when I needed it. I reached out to the professor of that course. That was Professor Margot Seltzer, who is a friend and mentor to this day. So for those in the audience considering career paths, I wanted to have two takeaways from this part. Number one, you don't have to know what you're going to do. You can go a lot of directions and still end up in a really good place. And number two, reach out to people, form relationships. People end up being a lot of the determining factors in kind of what you decide to do next and what opportunities you have. So I reached out to Professor Seltzer. She agreed to take me on one-on-one. So this was before the days of MOOCs and before the days of online classes. She had recorded herself giving lectures on VHS tape. So what I did was went to the library and I would take out a VHS tape and bring it back to my dorm room and watch that on the VCR and then meet with her about once a week to talk about the problem sets. Great experience. We are still friends to this day. Fast forward to the end of college, I still didn't know what I wanted to do, but a friend of mine who had graduated a few years ahead of me went to Microsoft and said, "You're doing computer science, Jessie, you should totally come to Microsoft." And I said, there's no way I would work for the evil empire, but if they want to fly me out to Seattle, sure, why not? And at that point, that spring, Boston in April looks kind of like that on the left, where it's winter and cold and brown, and Seattle looks lovely. Usually it's rainy, but that year it happened to be sunny when I was there, and I thought, this is pretty cool. And I was looking at a program manager position that turned out to be a great fit for me. So I did that, meant to go for about a year or two, did it for 6 years. And then I was in my car one day listening to NPR and heard them talking about the Human Genome Project and thought, that sounds like a lot of data. Surely someone must be doing something that combines biology, which was really my passion, and computers, which was the thing that I really enjoyed doing. Sure enough, the whole field of bioinformatics had come up as a field since I had graduated college in 1996, not to date myself. Again, Carol Sibley from University of Washington was a great influence and really helped me kind of explore the field and get to know it. So getting back to that info what? Biomedical informatics as a field was described by Ted Shortliff, who's one of the fathers of the field. It spans 4 different areas. So you can think of it going from the left side of the spectrum, the little bitty things, the molecules. Bioinformatics has to do with genes and proteins and metabolites. Imaging informatics gets a little bigger. Now you start to do imaging of the brain or the heart or some organ. Clinical informatics deals with the whole person level, and then public health informatics deals with the entire population. What's common to all of these is data. And so really there's just more data than a human being can know what to do with. Remember, the human genome is 3 billion base pairs. You need computers to be able to store, visualize, compute over, and really make sense of all this data. So we refer to the central dogma of informatics. Those of you on this broadcast, if you've gone to high school in the last 20, 30 years, probably learned about the central dogma of biology, which we now know is not completely true, but still a useful model. It goes from DNA to RNA to proteins. Similarly, in informatics, we go from data to information to knowledge. Data is just those ones and zeros. How are we storing the numeric values in the computer? So that's databases, data management, knowledge representation. The cool, interesting part comes next, where you turn that data into information. You use machine learning and signal detection and pattern recognition to make sense and put those numbers in context. And then finally, to knowledge, you have large-scale visualization, clinical decision support, taking that information you have in context. So the information might be a glucose measurement. The data might be a glucose measurement. The information is knowing that that is relatively high. And then the knowledge is, what do we do about that? If it's this high, you need to prescribe this medicine or change this diet pattern. A lot of people add on to this either action or wisdom as the next step beyond knowledge. So that brought me to Duke, working in an area that's been referred to as many different things: precision medicine, personalized medicine. I sometimes call it P-star medicine. It's whatever the popular flavor of the month is for what they want to call it. But it basically comes down to using more different kinds of data to intervene with the right person at the right time. And note, I talk about a person, not a patient necessarily, because ideally we can do it before anyone gets sick. So initially there was a picture that went around a lot of President Obama at the time standing next to a DNA molecule, which was very cool because we could all point to that and say, Mom, that's what I do. It was a little misleading though, because we've always known it's not just about the DNA. Technologies were enabling us to look at the DNA. But in addition to that, your environment and your lifestyle is always going to be extremely important for health outcomes. So in my time at Duke, I focused on precision medicine, particularly in mental health. That's an area really ripe for opportunities and in desperate need of a precision medicine approach. So again, as luck would have it, through a friend, I was connected talking with the people at Department of Health and Human Services when they were creating a data office and decided to create the position of a chief data officer. So you probably didn't know much about DHHS before the last couple of years. I didn't before I talked to them myself. It is an organization that's part of the state government that handles things like child welfare. Medicaid is the biggest it does, public health for communicable diseases, mental health services, deaf and blind services, various other things, vital records, birth certificates, and death records. And things like when you go to a restaurant and you see that little sign that says 98.5%, that's DHHS making sure that the people are going to be healthy because there's sanitary conditions in these restaurants. So Secretary Mandy Cohen is the leader of this, and you may have seen her up in the news flashes or the press briefings with the governor all throughout the pandemic. So you may also remember, I think many of us do, a year and a half ago now, more, on March 10th, 2020, there was a state of emergency declared in North Carolina. When that happens, often that happens because of hurricanes or blizzards or whatnot. In this case, it was the pandemic. And when that happens, mission control becomes at this building called the Emergency Operations Center. And this is a building that is near Umstead Park. There's actually a room called the Situation Room. Here's a picture of the doors to the Situation Room. And then there's a picture of us in the Situation Room. This was before when PPE was still in very short supply. And so we were socially distancing. You can't see in the picture that there was hand sanitizer everywhere we looked, but we didn't have masks on at that point. So this is where we congregated for a while until we all were sent home for virtual working. But some of the questions from the government perspective we had to answer were things like, how many cases are we going to see? When will our epi curve peak? The epi curve is that curve that shows how many cases there are. So what we realized is it's not really that it peaks, it's that it peaks and then it peaks again, potentially seasonally. How much extra PPE is going to be needed, and where can we get it from? There's a lot of shady exchange back in those days. Will we run out of hospital beds or ICU beds or ventilators? Should we shut down bars and restaurants, schools, or businesses? At this point, in 2020 hindsight, it seems obvious, of course, we were going to do that. But at the time, that felt like a very drastic step to take. And we had to figure out, does the data indicate that we need to do that? How many lives are going to be saved? How many jobs might be lost? All of these are trade-offs you have to make that data will help inform. And then how can we support families who are unable to work, whether because their workplace shut down or they're first responders, they're needed in the hospitals, but they don't have childcare because their kids' schools were shut down. So all of this was data driven, and we started out with really these buckets of data, and they really were sort of siloed buckets, very different containers, very different ways of getting them. The very first was testing. So the guy who he described himself, he's the guy that knocks down doors and hands out sandbags. He was the one to call LabCorp, which is a very large medical testing company in North Carolina, and say, how many tests did you do in North Carolina yesterday and how many of them were positive? This was clearly not sustainable. So we needed a better way to be collecting this data in an automated fashion that wasn't going to involve people calling people or even emailing people what the numbers were. Of course, once we did case testing, we were looking at cases. MedSurg or Medical Surge represented the data about how many hospital beds were available and how many were taken up. PPE was about the personal protective equipment, how many gowns and masks and shoe covers and you name it, gloves. Contact tracing early on and throughout the pandemic. This is different from how epidemiology is usually done. Usually when you get to the point of community spread, they stop doing the contact tracing. Contact tracing has been a big part of the response throughout the COVID pandemic. Finally, almost exactly a year ago, we're about to celebrate the 1-year anniversary of the first shots in arms. There were vaccines. So vaccination data has been key for the past year and is still a huge focus of what we're doing. Wastewater, we are testing the poop in the wastewater to see, and it generally tracks with cases, and that's another opportunity for surveillance across the state. And then treatments like monoclonal antibodies, trying to understand where those treatments are being given and to whom. We know that the COVID pandemic has disproportionately affected historically marginalized populations. And so we've put a huge emphasis on trying to improve health equities and reduce disparities. So I don't expect you to understand or even really be able to see this diagram very well, but this represented where things stood at the beginning of the pandemic, where these are 3 of those buckets. We have our cases and tests and med-surg or capacity. That was the stuff we had, the staff and the space we had. And each of those was collected in a very manual way. And then someone would copy and paste that into a PDF that would then be emailed to someone else who would then copy that into another PDF and mail it to 3 different places that they would then pass it on, send it to our dashboards on the website, send it to the governor and the secretary to inform their decisions daily. It was a lot of manual labor, prone to errors because you have the potential for human errors, copy paste errors, whatever it is. And from the very beginning, we were trying to automate this and say, how can we make this scalable? This is not going away anytime soon. We need to have a way to handle this. So I'm happy to report that today things are a lot smoother. We have all of our different buckets at the bottom. They're in much more orderly, automated methods for getting them. We have what's referred to as an ETL process, which means extract, transform, load. We load them into a central database that is in the cloud. And then we use that to populate our dashboards on the website. So I'm going to show you that in a minute. That is the source of North Carolina data. So when you see NPR or the News and Observer or WRAL reporting on those numbers, those come from our website, which comes from the databases which we've been collecting. So just to give you a really concrete sense of why this is hard, doesn't seem like it should be so hard, but you might think a bed is a bed. If we're asking how many beds are available for COVID cases, there are beds and there are ICU beds. And some of those are occupied and some of those are not. Seems pretty straightforward. But when you come down to what is our capacity, what could we handle if we have more COVID cases? You might have something like physically available beds. So a given hospital might have beds, but they don't have staff members assigned to them because they just don't have the workload for that. It makes no sense to pay people to be there if you don't have patients. Above that, any given hospital is licensed for a certain number of beds, even if they haven't physically set up those beds. So that's a larger number. Beyond that, there's these outpatient and observation beds. So beds that are not really meant to keep someone overnight, they're just for kind of a little while. And then there was this concept of surge beds, and that had many different definitions. Some people thought of it as the physically available beds that weren't staffed, that's their surge. In some cases, it was, well, we're licensed for this, so we could go up to this if we needed to. In some cases, it was, we could put people in these outpatient beds. And then sometimes it was, we've got a tennis court next door. If we really needed to stick some gurneys there, if worst came to worst, we could do that. So getting that standardized, first of all, across hospitals in North Carolina, and then federally, and trying to align with the federal standards was a challenge for a while there. Another aspect of data that we were looking at a lot, you might remember people were talking about flatten the curve, flatten the curve. So this is the curve we were talking about. Along the x-axis is time. Along the y-axis is how many cases there are. And that dotted line shows the capacity, how many beds we have in North Carolina. What could we possibly handle in any given region for people with cases? If we didn't take the protective measures, 3 W's, remember, the washing your hands, waiting 6 feet apart and wearing a mask, we were going to look at that red curve and we were going to exceed our capacity and people would needlessly die. We're seeing this, we saw it in different countries around the world. I think I just read or heard on the radio that Germany is facing this right now. Again, with protective measures, we could flatten that curve, we could lower it so that it's not that people weren't going to get sick at some point, but we would be able to have the capacity, we'd spread it out more over time. So we were trying to model with the transmissibility that we knew was going on and where the cases were, what that looked like. You can compare this to what we see during hurricane season. You get this nice, neat curve that looks like where the hurricane is going to go. We had a similar curve showing where we expected the cases to go. But remember that we don't know the answer to this. When you see a nice, neat curve like this, it's actually an average of a whole bunch of really messy models that people have run that say that it could be anywhere in these spaces. So they kind of average them out and say, this is the most likely path. One of my proudest moments in my career was when I was turned into a comic strip character for this in the Duke Alumni magazine to explain just what I told you now. Importantly, you can't improve what you can't measure. And so, as I mentioned, COVID has really disproportionately impacted people across the state. And so we wanted to know the distribution of race and ethnicity across COVID cases, COVID deaths, who is being tested for COVID, and then who is being vaccinated for COVID. These are very actionable pieces of information because if we know where there's not enough coverage, we can try to do more outreach there, incentivize providers, incentivize insurers to get their people covered. And so what this enabled is really national recognition of this. Top-down leadership, Secretary Cohen made it clear that this was a huge priority, that we needed to collect this data. And to say it was just too difficult to add into a clinical workflow was unacceptable. So this has enabled us to do things like tracing over time. On this graph, the different colors represent in any given week for all the people who were vaccinated, what % were of different racial demographics. And so we can see over time, the purple is white and started out a very high proportion of people. And you can see over time how that's gotten smaller and the other areas have gotten larger. So as I mentioned, we have these public dashboards. We also have a public map that shows the rate of vaccination in each of the census tracts. So I'm going to really quickly show you those. How am I for time? If I do a little bit, I can see the clock actually, we're doing okay. Okay, so I believe they're putting the link to the dashboard in the chat. And you have here the summary numbers. Unfortunately, you can see these last few days, we're seeing a spike, this post-Thanksgiving spike. It's also seasonal as the weather gets colder, possibly drier. I forget if that's a factor. I'm not the epidemiologist, I'm the data person. We can see that we're spiking up here. And then we measure how many tests we've done in a given week and how many people are hospitalized. So remember, that's a key statistic because we need to make sure that we are keeping up with capacity. We also have maps down here showing how many cases we've had recently. And there's a lot of different options here. You can do it by county or zip code. You can do it by total cases or rate. If you do it by total cases, you're always going to get the relatively populated counties as having the most because they have the most people. Also want to mention over here, we have all of the navigation where you can look at vaccination data, cases, testing over time, hospitalization. And if you're ambitious and want to do any kind of data science related projects, the data behind the dashboards tab enables you to download all of this data. And then if you're proficient in R or an Excel whiz, you can do some fun graphing on your own. The other thing that should be sent, I think I sent the link to this, is this dashboard that shows, I have a mouse, for every given census tract. So census tract comes down to slightly bigger than the neighborhood. This map shows, the red and the blue show what's called social vulnerability index. So that relies on a number of different things. It's income, level of education, transportation, race, ethnicity, language barriers, all of these kinds of things of how vulnerable a given area is. In Raleigh, you can see the red are the more vulnerable areas, the blue are the less vulnerable. And then these teal dots represent the relative level of vaccination in that space. So you can click on them and see in this census tract, this zip code, what number vaccinated, what percent ages 5 and over that represents. So very high vaccination in this area. You can also filter and say, I don't care about the ones that are really a lot of vaccination. I care about the ones that are socially vulnerable and have a relatively low vaccination rate. And so from the DHHS perspective, as we do partnerships with community-based organizations, we would choose one of these census tracts and say, for example, if we're sending out a FEMA truck that's doing vaccines on street corners, we might send it there and try to increase the uptake there. So that is the presentation for tonight. And now there's an activity that the students are going to lead you in playing around with these dashboards so you can get a feel for them and hopefully come up with other questions that you would be able to ask with the numbers.
Okay, so I'm going to be asking you guys a couple questions and you will be using the database linked in the YouTube chat to figure out what the answers are. And then we will, of course, go over the answers one by one after you guys have a couple of minutes to go through them. So your first question is, how many people were hospitalized on Thanksgiving, November 25th?
We have a guess of 1,047 people.
That's
Okay,
correct.
we have a guess of 1,047 people. So do you want to tell us the answer?
That is correct.
Oh, wow, okay. Our second question has a couple parts. So the main question is, what was the highest number of statewide cases for a specific day and on what date?
I should have written the answers down on the paper because it's actually in the end of the slides. Are we still showing the slides?
I will put them back up.
No, don't actually, because then we can look at the answers without.
Oh, okay, yeah. I took the yeah, it's just Kayla right now. Yep.
Okay. There's the answers.
2,350.
Oh, close.
I don't know what question I was guessing for.
I think that was the most number of cases in a given day, but that is incorrect. I wish it was correct. I wish we only got that high.
Yeah.
We actually got higher than that today.
Okay, we have September 13th with 23,714. September 13th of 2021.
I think that might be number of tests done. Is that?
So we're not.
Oh, 2021. Actually, I may have not seen that one. So this is where I was doing it on my phone and may have missed that one. That for memory, that sounds right.
Okay.
Yeah.
And then what was the second highest number of cases and on what date?
I also might have screwed up the answer to this, but I'll still be interested to hear what people say.
Do we have any guesses?
We have one message that says 3,780 on yesterday.
That was not second, I'm sad to say.
January 7th, 2021, 10,614.
A little
That
higher
was
than that.
around the right date, but I think it was a different number. And I don't know if people can hear me talking that before we started this, I got these numbers from my phone before I realized we had Wi-Fi. So it's possible I missed a span.
Any more guesses? Should I share the screen for the answer, or?
Oh, we have a couple questions left. Okay.
Yeah, there's a couple questions.
Okay, and then between these two numbers, which do you think is more reliable and why?
We might actually skip this one because if it's not the two I was thinking of, it could be not relevant. Let's go on to the next one.
Okay. The next question is, who has the higher rate of vaccination in Wake County, men or women? So you have a 50-50 chance.
Bonus points if you say what the rate is for each of them.
Ooh.
I'll try to find it on my phone. Because we know how well that went.
Women?
That is correct.
All right.
Oh, okay. Final question. What percentage of the population over the age of 12 has been vaccinated in your census tract? So you'll want to look at your specific area.
Going back to the previous question, Sandy said females at 62%.
That's higher than I remembered the disparity, but let me look. Actually, I can use this now, right?
Yeah.
Click on the team. Oh, wait, you're right.
There we go. Yeah. So that was vaccination. Demographic data. Cumulative. Oh, there's a tricky part to that. So 69% was what the total population of the total percent of the male population. But if you do it by people, percent of people fully vaccinated. So this is not what percent of that population, but what percent of the people who did get their shots in a given week, which, come to think of it, was not how I phrased the question. I apologize for that. So the bottom line here is I was hoping that people would explore, there's different drop downs and different numbers. And so you can get at the cumulative total of the whole population, or, let me step into here, cumulative total of the population, or understanding what percent of the people who were vaccinated in a given week were the different racial demographics, or other demographics, as the case may be. Hopefully people have found their demographic or their census tract.
Okay, I think we're going to go into a Q&A session. So we have a couple of questions. You can put that in here. Okay, so the first question is, have you ever worked with genetic engineering specifically?
I have never worked with genetic engineering myself. I've done more the observation of the genetic data to understand how genes work and which ones we might be able to target for diseases, usually with small molecules. I haven't really looked at the tweaking of the genes themselves, but it's a very exciting area.
Mhm. And you mentioned you were interested in neuroscience, so could you potentially offer a little more information about the Human Connectome project?
I have heard of it, but I really know very little about it. I think it's the thing where they're mapping the brain and all the different parts of the brain and how they connect to each other. If that's the right answer and that's what I'm thinking of, that's going to really help us to understand mental illness, as I described, psychiatric disorders, neurological disorders. Very exciting work there, but I have to say I'm not an expert in that area.
We have another question from Taya P79. What type of modeling do you do for variants, and are there different projections for the Delta, Omicron, etc., or is it just COVID cases total?
Right now, we're doing COVID cases total. We do expect the Omicron to come to North Carolina. It's probably over here. We just haven't detected it yet, but we are monitoring for that. So the modeling doesn't do the variants themselves, but it does take into account what's called the R value of how transmissible it is. And so Delta took over because it was much more transmissible, and that was factored into the modeling. And I'm sure they're figuring out what the appropriate R value is for the new variant, and that will affect the models as well.
Okay, and then we have a question from Sandy. How can scientists track the COVID stats of people who live in areas without proper healthcare facilities, and can they?
That is a great question. So there is definitely a dearth of healthcare facilities in certain areas. Telehealth has actually made a huge impact during COVID, as people didn't want to go into the doctor's office. Some of the rural areas that previously had a really hard time reaching doctor's offices have now been able to get care through telehealth. We do have different regions, and the hospitals work together to try to make sure they can distribute the patients. But fundamentally, there are some counties that only have one hospital and some that don't have any, and you have to travel a long way to get to a hospital if you do have severe COVID.
Interesting. So we have another question from Alexa Bernard. Is artificial intelligence a potential tool for improving the efficiency of data collection, or is it already being used?
It is definitely, so it's an interesting way of phrasing it. AI is definitely being used. Actually, on my way over here, I was listening to a panel of people from Google and Apple and various pharmaceutical companies. AI is being used everywhere, but different people have very different ideas of what AI means. So in some cases, it just means something like a script that's going to notice if a number goes up 3 times in a row and alert someone and say, alert. So maybe, for example, a refrigerator or a freezer in a bio lab that the temperature is going too high. Some people think of that as AI. That's a very simplistic version. Another, at the other end of the extreme, is a colleague of mine from Duke sent me a link to a poem that her student's algorithm had written based on having been trained on the web. And it was a pretty compelling poem. I would have believed it was written by a human being. So different aspects of AI are definitely being used. The part I mentioned, I think the phrasing of the question was in data collection. It's less about data collection, more about data analysis, and that data to information, information to knowledge aspects of the central dogma.
Do you have any examples of that?
Oh, so many. Let's see. So, of course, my mind's going blank now. I'll mention actually, that's not a biomedical thing. So in hospitals, one of the really common things that we've seen is people using machine learning to predict who is likely to get sepsis. So over the course of time in the hospital, you have people with a lot of measurements being taken, their heart rate, their oxygen level, their breathing rate, and a lot of other measurements taken. And people have used AI to try to predict who is going to go into septic shock so that they can proactively intervene there. Another area, a colleague I worked with used machine learning to predict who among people who are having radiation therapy for cancer are going to need admission during that so that they can get extra attention beforehand potentially extra visits with clinicians to try to avoid having them be readmitted into the hospital. So those are just a few of many, many examples of machine learning being used in this space.
Great. So another question from Pranav Wag. How important would you say that statistical programming in languages like R is?
I would say extremely important. I'm a huge fan of R, and I want to say upfront that when I first used R, I hated it. I used it for a class. I found it extremely non-intuitive, and I promptly forgot it after that class. And then I took another class that needed it, and it was a little more familiar. And then as you get more familiar with it, it is a pleasure and a joy. There's a whole community around it. Check on Twitter, and there's women in R, and there's all sorts of people doing really cool things with R. So R is just one of many tools. A lot of people have a preference for Python. There's a lot of different things that can get the job done, but familiarity with those is going to really prepare you to do some interesting projects, potentially get some interesting jobs.
Nice. So another question from Alexa Bernard, has COVID-19 affected data science and how?
I don't know if I would say, well, I would say COVID-19 has affected everything. So it's affected data science in the ways we're trying to apply data science, in the way people have done their research and formed their groups, and the way we've done conferences in the space. So I would say it has had an impact on data science as much as it's had an impact on many things, and that data science has had an impact on COVID in the way we analyze data.
So it's given you kind of like experience analyzing it.
Yes, many people who studied other things suddenly dropped everything and started applying their data science approaches to COVID.
Yeah. And then another question from Nandini Gupta, how do you foresee the area of personalized medicine changing in the future?
That is a great question. Personalized medicine has been hyped up a lot, and it's been around, the concept has been around for 15 years or so at this point, and probably longer than that in other with other monikers. I think we're going to get a lot better about it. I think people started looking toward this after the human genome was sequenced in somewhere around the year 2000. And we thought, okay, now we're going to be able to personalize everything for people's genes. But there were a few flaws with that. Number one, as I mentioned, we know it's not just about the genes. Number two, getting the sequence of the genome meant we had the parts list, but we still don't understand how things interact. So today, up until now, there's been some massive success stories in cancer, in pharmacogenomics, meaning who to give which drugs, and then in newborn diseases, because when you're newborn, there's not that much environmental impact that you've had so far. We've seen some successes there. I think over time, we're going to see more and more in other areas as we get more numbers, higher N values for the kinds of studies we're doing. That we're going to start to be able to understand better the mechanisms behind different diseases, not just those success stories we've seen so far.
And then another question from Nandini, what is your favorite aspect of bioinformatics, and how could a student get more exposure to bioinformatics?
I'm so glad you asked. Oh, so many things. Okay, two things that are my favorite parts of bioinformatics. One is just the possibilities it opens up. There are so many places you can apply it. There are so many. So you saw my career path went all over the place. And even within informatics, I started out in genomics, but then I moved to clinical informatics, but then I moved to public health. All of these are really about that sort of data science applied to whatever you want it to do. So natural language processing, data standards, databases and algorithms, they all apply to all of these spaces. So many valuable things you can do to have impact in society and really positively impact people's lives. The other part might surprise you. My favorite part of informatics is really the community, the people that are involved in it. It's a relatively new field. So it's funny, I mentioned in the slide that Ted Shortliff is one of the fathers of the field. My husband is a chemistry professor. And so the fathers of his field died 200, 300 years ago. But in informatics, it's a relatively new field and a really tight-knit group. And we go to conferences and it's just stimulating and fun. And you chat with people in the hallway and get really excited about the different ways we're applying informatics to actual problems.
Mm-hmm. And then how do you think a student could get more exposure or learn more about bioinformatics?
So many online resources. Thank you for reminding me of that part of it. Many online resources for AMIA, which is the American Medical Informatics Association, which is my sort of professional home and family. There are conferences, there are first look events where we get people who would not normally be exposed, and they get kind of the funding to go to the conferences. There are high school competitions for design for projects, so definitely look into that. There's also a lot of online resources beyond AMIA. Just if you search for kind of, Coursera has courses, and there's just a ton on YouTube, and bioinformatics.org, I think, had some training. So lots of things available. Also worth mentioning, back to the R question, Hadley Wickham is this sort of god of R and use for data science and bioinformatics. And he has his textbook freely available online. It has code you can copy and run and try, and is an amazing resource. Basically, I at one point sort of walked through most of the book to just learn what he was teaching.
Nice. So another question from Pranav. So he says that he saw that the map pointed out social risk areas, and the map may have worded this differently, but what are some ways that the information on the map is turned into measurable impacts?
Good question. So the social vulnerability index, that is relatively static for the areas we're looking at. The part that changes over time is how many people in that census tract have been vaccinated. So that's the part that informs action, that we're able to say, look, we're really falling behind in this area. We need to try to reach out to, whether it's partner with a church in that area, or as I mentioned, send a truck to do mobile vaccines. On the social vulnerability side, that's been, so social vulnerability and all the different things that go into it is a huge issue, and something we tackle in DHHS more broadly through outreach, through trying to get people hooked up to the services they need. One of the things I'm most excited about at DHHS is a program we have called Healthy Opportunities, which has many aspects, but it basically recognizes that we're spending all of this money on healthcare in America and not getting good outcomes. And it's going to be really hard to maintain, to control your diabetes and your glucose levels if you're living on the streets, or if you don't have access to healthy food, produce, fruits and vegetables. And so it is a program that allows us to use medical dollars that would normally be to pay a doctor to give an x-ray or put a cast on, and instead to use those for things like a referral for a healthy food box, or help finding housing, or transportation to your doctor's appointment. That can't be assumed. There's a lot of people with limited transportation capabilities. So understanding the reasons for the different social vulnerability in the different areas helps us to connect with people and try to make sure that they are getting hooked up with the programs they need, whether it's Meals on Wheels or vouchers for transportation or whatever it might be. Definitely Google Healthy Opportunities North Carolina and NC Care 360, which is the name of the platform we use for that. Very cool work there.
Mm-hmm. Great. And then we have another question from Nasira. How do you think the new Omicron variant is affecting the number of cases, and is it something that we should be concerned about?
Good question. I couldn't say how it's affecting the number of cases just yet. Of the cases we have in North Carolina, the vast majority are still Delta. I do think we're going to see it. We're going to see it a lot. It's all evidence so far shows that it's more transmissible than the Delta was, and that it, like Delta, it can cause some breakthrough cases even among people who are vaccinated. So A, get vaccinated if you're not already, for sure. B, get your booster if you have had if you're 18 or over and had your first shots more than 6 months ago, or 2 months if you're J&J. But yeah, I mean, both the fact that seasonally it's getting cold, we're getting to the holidays, people will be together, we're going to see cases go up, and some of them are going to be Omicron. We don't know yet how high that's going to go. And so we'll be modeling, but there's only so much you can do with modeling. So we'll keep an eye on it.
Yeah, and about that, I know in the winter, a lot of people tend to get like the flu and other illnesses. So are you guys also doing similar tracking for that?
Yeah, so actually some of the tracking that we have done in COVID started out tracking for the flu before COVID was even an issue. A lot of the hospital surveys that were going out were for flu. We're also worried about what's referred to as the twindemic. So we are getting to flu season. Even before the COVID pandemic, we would get to the season and tens of thousands of people die every year from the flu. And so also get your flu vaccine. There's also ramifications. People are probably familiar with this, but remember that if you stay safe from COVID, but other people are getting sick or you're getting sick, if hospitals are full of COVID patients, they don't have the resources to handle other people, to do elective surgeries or even to do critical surgeries, timely procedures that are needed but are not COVID. So we really need to get as many people, if your family is holding out, try to convince them, try to send them to DHHS, has a lot of really useful information about vaccines. Vaccines are going to be our best tool out of this.
Thank you. So Sandy has a question. How do you think the government will respond based on the statistics that have already been collected?
So we've been using that data the entire time to drive the decisions. So when we had made the decision to close schools, to close businesses, all of that has been driven by cases. We were, I don't know if people remember, but there was the full lockdown, phase 1, and then we were hoping to move to, I think it was phase 2. The numbers were not what they needed to be. We had hoped to be doing better with the numbers at that point. So we said, we can't take off the restrictions that we have. We're going to move to what we refer to as phase 1.5. Where we lessen some of the restrictions, but not all of them. So the data have really been driving all the decisions made in terms of mask mandates, in terms of school opening and closing, in terms of businesses, bars, restaurants, et cetera.
Thank you. And then we have another question from Nasira. Do you think enough is being done to get everyone vaccinated as fast as possible? And if you had the opportunity to implement a new plan for the vaccine, what would you do?
Wow. I think we're doing all that we can in a really stressful situation. So I don't know how much of a sense you've got about this, but really for the past 20 months, people have been working behind the scenes. We have calls every day, multiple times a day. In fact, many people back to back or triple booked on these calls, trying to figure out how can we reach the people who need it? How can we get vaccines to the places where it's needed, where we're going to have the most impact? Analyzing, there's some people that are, really were right there in line to get vaccines as soon as they were available. There's some people who, mostly through misinformation, I'm afraid, just are never going to be convinced. And we don't want to waste time on people who are just never going to be convinced. But there's people on the fence, and we really tried to target communications to be where it's going to have the most impact. So I have been incredibly inspired by the leadership of DHHS, by Secretary Cohen's leadership. I think that we're doing everything we can. And I don't think I would do anything differently. One thing that I hope we do more of moving forward is to make testing more widely available. It's already as available as we can do, but we're seeing, actually, we just saw that you can get reimbursed for at-home testing by insurance companies. I would love to see us go a step further and make at-home testing just free without having to file for reimbursement. I think that would be great, but I think time will tell, and we'll see what happens in the next several weeks or months.
Yeah. And then we have another question from Zima. How do you think your job will change as COVID evolves or impacts society?
So there's two ways to interpret that. My job at DHHS and my job kind of as a data scientist. I think actually there's sort of a microcosm of itself. It's been a delight over the last couple months to finally be able to kind of peek our heads up and say, okay, like COVID's not completely under control, but we've kind of done what we needed to do with respect to automating and collecting the data. There's still a lot of work being done on the dashboards and other areas, but we're able to say, okay, let's get back to what we were doing before that, healthy opportunities that I mentioned, different aspects of data around DHHS that we want to use it for. And I think similarly as a data scientist, that COVID has been, I don't want to say a distraction, but COVID has been a really motivating event for a lot of people. And a lot of people are working on it. And then little by little, we're going to be able to start saying, okay, COVID has become endemic. It's going to be here, but we've kind of understand it and know what to do at this point. Now we can get back to our day jobs, whether it's looking at cancer or cardiovascular health or mental illness or whatever people were working on before.
Great. And then this is a fun question. Is there anything you learned in your time as a marine scientist that you carried over to your work today?
So I should say I never studied marine biology. I just did the scuba diving and the certification. No, the main thing I learned is that I get really sick on boats and that I shouldn't do that as a career.
And then what are your favorite parts of your day-to-day job?
Ooh, my favorite parts of my day-to-day job, not Zoom calls, the chance to really think strategically of where do we want to go? How do we want to change things? So sometimes you just need someone to say, this is where we should be going. It doesn't make sense to have done things this way. We're going to do things this way now. And so the chance to have impact on, we have 10 million people in North Carolina, the chance to have direct impact and try to make their lives better is one of my favorite parts of my job today.
And then what are the biggest challenges in your field right now?
Overcoming the hype is one of them. So as I mentioned, we've been talking about personalized medicine for a really long time, but fundamentally, I could give you, I'm looking at you, a special readout of exactly what your best bet is based on your genome. Eat healthy and exercise. So people get really excited for what we can do with the genome and the personalized medicine and all. But we really have to remember that we are kind of somewhere on the hype curve and need to focus on what's doable. I think technology is going to let us have access to more and more imaging and molecular data and understand that better. It used to be compute power, but really we've got a lot of compute power. We are data rich, and as they say, data rich and information poor. So we have so much data that we know more than we know what to do with. We need to, I should say, your more advanced machine learning algorithms. That's something a lot of people focus on, is getting, the higher area under the curve of your ROC curve to say the accuracy here. That's not what this is about. Implementing it, putting machine learning into practice, figuring out how, for example, clinicians are going to interact with the system that's going to tell them to do something different from how they were doing it already. How to even have them interact with it in the course of a really busy day when they have 10 minutes to interact with the patient, and then they have to spend time in their pajamas documenting everything they've done. So implementation science and really understanding kind of the interaction that people have with computers is one of the biggest challenges right now.
Awesome. And then a question from Nandini. I'm sure they share a lot of common aspects, but what is the difference between biostatistics and bioinformatics?
Great question. So yes, there is some commonality. I actually have given a different version of this talk where I show a little bit of that. So I should give the disclaimer that I'm not a biostatistician, and my biostatistician friends might be appalled to hear me describe it this way. But biostatistics really focuses on the numbers, numeric modeling of the phenomenon being observed. Informatics has some of that, but I should say that informaticists are often not trained as deeply. So I, for example, don't know how to do a power calculation. There are a lot of questions that I can't do, and I turn to my biostatistician friends to ask, how do you account for this? Or what statistical tests would you use here? Informatics, I think, has much more breadth. So understanding how the data is collected, metadata, data about the data, governance, workflows, the person interaction with data, decision support, decision analysis, all of those things, I think, come into informatics in a way that is less focused on in biostatistics.
Mm-hmm. And then what were some projects you worked on before COVID?
So Medicaid transformation has been going on in North Carolina. Before COVID, all eyes were on Medicaid. We are one of the last big states to move from what's called fee for service, where you pay the doctor for an x-ray or a cast or a doctor's visit. And instead, we have what's called managed care, where you pay a doctor, you say, here's a person, you're responsible for that person. We're going to pay you $5, $10 a month or so to keep that person healthy. If they never come into the office, you're golden, you get to keep that money. If they get really, really sick, that's on you. You're going to have to figure out how to make them healthy. And so that incentivizes providers not to do more and more procedures, but to try to really keep the person healthy, keep them from getting sick in the first place. In grad school, I remember one of my professors, Russ Altman, describing all the different possible ways you can pay for healthcare and why all of them are problematic and flawed. But there's been a huge focus on not buying healthcare, but buying health at the state, and not just trying to pay for procedures, but trying to keep people healthy. So that was a huge focus. That, and then accompanying it, that healthy opportunities I described of not just paying for the medical stuff, but understanding that food, transportation, housing, interpersonal violence, these are all part of a person's health and well-being.
Mm-hmm, thank you. So it looks like this is all of our questions for tonight. Thank you,
questions.
Dr. Tenenbaum. Yeah,
Thank you.
We had a lot of great questions in the chat today. And then thank you all for watching. I hope you were amazed by everything you learned today. And we would also like to thank the museum's digital media team for helping put on the cafe. Don't forget to follow Teen Science Cafes and mention us on Twitter, Facebook, and tag us on Instagram. Also, please use the QR code on the screen or go to the following link that will be sent in the chat to complete our survey. The survey will also be sent out in a follow-up email that you registered with when you were registering for the cafe. Completing the survey enters you into a drawing for a $10 e-gift card of your choice to Amazon or Starbucks. Be sure to complete the registration form and tune in for next month's cafe on Friday, January 7th with the museum's own Dr. Patrick Trudhart to learn about astronomy. And then thanks again for joining tonight's Teen Science Cafe. Smash that subscribe button, hit the like button, and destroy the bell notification button to make sure you don't miss some premium content from the North Carolina Museum of Natural Sciences. Don't forget about filling out the cafe survey because your feedback matters and you'll be entered into the gift card drawing. My name is Kayla, and these have been your cafe coordinators. Stay safe this December and have a happy and healthy holiday season. We hope you have a wonderful, wonderful winter, and we can't wait to see you next month. Bye.
Bye. Thank you.
Thank you.